You're listening to Risk and Resolve, where leadership, business, and risk management collide. We bring you real conversations, sharp insights, and strategies for success. And now for your hosts, Ben Connor and Todd Hufford.
Good morning, everyone. Thank you guys for being here. While I start talking, I'm going to invite our panelists up, Matthew Browning, Joel Hungay, and Guy Volley. Before we begin, obviously Ben mentioned it earlier, we have a little bit of a unicorn with us as far as a hospital that is really in alignment and focusing on transparency, which you don't always see. I want to begin by framing what the Hancock Community Health Plan truly is and what it represents. At its core, this community-driven health model built in Hancock County is designed to bring employers and a local health system into true alignment. Instead of operating in silos, this model connects employer benefit strategy directly with local and coordinated care delivery. The goal is simple but ambitious: better outcomes for employees, greater predictability for employers, and a more sustainable healthcare ecosystem overall. For those of you that are in the room right now evaluating your benefit strategy, thinking about renewals, cost trends, engagement, and long-term sustainability, this conversation truly does matter. Many traditional approaches simply aren't delivering durable results. The Hancock Community Health Plan challenges the old way of doing things and asks, what if healthcare worked better because incentives were aligned? What if care was coordinated locally instead of fragmented across disconnected networks? And what if employers weren't just purchasers of healthcare, but strategic partners in how it's delivered and the health of their own community, which I know they'll speak to specifically Hancock County and the health that they're seeing and how it's improving. But today's conversation isn't just about geography, it's about possibility. It's about whether alignment between employers and a local care delivery can create better outcomes anywhere. Today we have three leaders who bring different but complementary perspectives to that discussion. First, I want to introduce Guy Volley. Guy is a benefits advisor at Connor Insurance with more than 18 years of experience helping small to mid-sized businesses design strategic, cost-effective benefit programs that attract and retain top talent. His focus is simplifying complex healthcare challenges by building tailored solutions that not only lower costs for employers and employees, but also enhance benefits without compromising them. As a resident of Hancock County, Guy is passionate about seeing his community grow and flourish. He coaches the Greenfield Central varsity softball team and participates in adults men's basketball ministry focused on mentoring young men in the Indianapolis area on and off the court. For Guy, blending his professional work and benefits with his commitment to community just seemed like a natural next step. Next, we have Joel Hungay, Executive Director of Wellbeing and Employer Strategy at Hancock Health, also a serial adventurer, as I've learned. Joel has been instrumental in shaping how a health system partners differently with employers. In his role, he pioneered the infrastructure of well-being, a model reshaping how communities thrive by integrating purpose, health, and engagement. Joel's life reflects that philosophy. In addition to his work at Hancock Health, he is a mountaineer, musician, and Netflix Outlast survivalist. He might be the coolest one of us on stage currently. He now produces adventure media exploring courage and connection, two qualities that were essential in building a strategy that actually works. Joel believes well-being flourishes when innovation meets purpose and that every person deserves the opportunity to thrive. Next, we have Matthew Browning. He is a Chief Administrative Officer for Hancock Health. Matthew oversees non-clinical operations to drive growth strategy and exceptional patient outcomes. He is a seasoned healthcare executive who's previously held leadership roles at the Indiana Hospital Association, including Senior Vice President of Member Solutions and Engagement and Chief Privacy Officer, supporting more than 170 hospitals statewide. Matthew understands how hospital sustainability, employer strategy, and market dynamics intersect, and why collaboration across these sectors is essential if we want true change. For those of you who are in the room that are benefit decision makers, I invite you to listen through this lens. Where are your biggest cost drivers today? Where are your employees disengaged from the care that they need? Where are you frustrated with the lack of transparency or predictability in your plan? Because what we're exploring today is whether a community-aligned model can reduce fragmentation, improve that engagement, and create a more sustainable path forward for both the employer and the employees. So, and as we're going to continue this, it's going to be a more casual conversation as well. To set that stage, Joel, I'll start with you. why did this need to exist, or what started the conversation for you at Hancock Health of implementing this in your community?
Yeah, well, hey, good morning, everybody. Joel Hungate. This is critical. And I think it's really critical that we all level set on a common lexicon when we talk about the problems of healthcare, right? Just ask any of our legislative friends. There's a just plethora of misconceptions about what the real problem happens to be. Oftentimes, the easiest thing to point at is price. Price, price, price. The problem is healthcare doesn't have a price problem. Healthcare is a total cost of care problem. These are two very, very different things. If you focus on price, what you will end up with is a couple systems consolidating all healthcare across your state, as price will drive out independent local healthcare that is proximate to the needs of the community, that can invest in that community in the way that we're describing here today. Now, Hancock County, great example. Flashback with me to 2011, and I'm from Hancock County. I'm an engineer by trade, so don't let me overwhelm you as we get into the numbers. It makes my little engineering heart happy. But 2011, we were the 28th healthiest county in Indiana. Indiana, not by and large a healthy place, right? But we had the 4th highest median household income. So when you look at that, the discrepancy between affluence and health outcomes was very stark for us. And we started asking why. And at Hancock Health, as an independent local health system that is proximate to the needs of the community, pride ourselves on being local, focused, innovative, kind, and responsive to that, taking that mandate seriously, because we're not there just to do healthcare, because all spheres converge in health. It's economic development. It's the elevated placemaking. It's destination development. It's the quality of life for everybody in our community. So we decided to invest in this idea called the infrastructure of well-being. We began with these medical fitness campuses, where, if you can imagine, using physical activity, nutrition, healthcare education, co-located with primary care, labs, imaging, diagnostics, specialty care, physical therapy, where you create a new home base for health, give people no other reason to go anywhere else. And we did that in a direct-to-consumer or direct-to-employer membership model. So cash money, no evil insurance overlord in sight. We literally just went to people, offered an incredible service, investing in their family early and often, so they didn't need the big, scary, expensive things that we do at the mothership in Greenfield at our big main campus, right? We started in 2011 with one center, expanded to another one in McCordsville, if you're familiar with Hancock County. It's our northwest corner of the county, in 2016, and then opened our flagship facility in New Palestine on December 28th of 2020. And to give you an idea on the cascade of what's happened since, we went from a couple thousand people in that ecosystem in a county of now roughly 92,000. We have 22,000 plus covered lives working with us in this direct-to-consumer, direct-to-employer capacity. We've gone from the 28th healthiest county in Indiana to 3rd and now top 4% in the nation. We've caught the attention of Bobby Kennedy, Dr. Mehmet Oz. I was out in DC a week and a half ago having these exact same conversations about how do you start to align incentive in a way that moves the needle for entire populations. Because remember, if we all focus on reducing the total cost of care, everyone can win. And the health system doesn't have to be a black box where your plan spend goes to die. Health systems that are engaged want to be a partner. They want to be at the table saying, where are your major cost drivers, as Kimberly just mentioned? And what can we do about it proactively? Don't just let healthcare happen to you, right? In the healthcare systems that are going to survive, because we have 3 options, especially as an independent, smaller health system. You can either innovate or you will consolidate or liquidate. That's it. And the idea of price controls in healthcare is not a free market system. We don't have pricing power until we go directly to the consumer or directly with the employer and work on addressing this in a proactive way. What you will see if you don't address it from a total cost of care standpoint is mass consolidation, less access and options for your people where they live, and you're seeing it now. That's the fruit of focusing solely on price. And if we don't align all of these incentives together, healthcare is only going to get better at fee-for-service, which is reactive, which is what they get paid to do now. It's what we get paid to do now. We can't do that forever. We've got a $5 trillion problem in the United States. It's not going to be solved by doing more fee-for-service healthcare. So with that was kind of the impetus for us to lean into this model. We built this infrastructure of well-being with initially these medical fitness centers, then started to wrap and say, oh my gosh, We're doing clinical exercise. We're engaging people where they live, where they are, addressing social determinants, the socioeconomic barriers to sustaining health, and saying yes to what's going to change your health outcomes. And then we ask the question, well, what if we wrap that around our employer partners? What if we opened up lifestyle medicine direct primary care clinics and created that as a part of the ecosystem? What if we started to do now AI-empowered risk cluster analyses to focus where the care needs to be at the right place, the right time, at the right intervention, and sustaining that and pointing that laser-like focus of reducing the total cost of care at real problems has allowed us to move the needle in our population in a way that's now becoming national news. So we're really excited about what we see. We couldn't but solve this problem, because if we didn't, Hancock County was going to suffer for it. And we see that mandate as the county hospital that's responsible for not just health, but economic development and opportunity for everybody. When those spheres all align in health, incredible things can happen.
Yeah, and then Guy, I'm going to jump to you next on that. So we're talking about the people of Hancock County really needed this. What did you see from as a broker on the employer side? What was really the need or the why behind it there?
Well, hello, everybody. What I started to notice, being part of the community, just talking with community members, being a coach, I talked to a lot of parents, a lot of business owners, and they're saying, healthcare, what are we going to do about the healthcare spend? And, how can we make things better? And I said, well, I got to think of what can we do to help engage the local hospital with the local community. And large companies have this ability to do these direct contracts. And I said, well, what if we can do a direct contract for smaller employers directly with the hospital? And this idea came on. I called the executives at Hancock Health and I said, I got an idea. They said, wow, that just aligns exactly with what we're trying to accomplish. They said, we have a DPC model, direct primary care model, that goes directly to consumer and to businesses. Why don't we incorporate this into the health plan and then have a direct model where the employees can have $0 deductibles, $0 cost of care, eliminate that access. And the communities they love to hear how are we going to make this happen? How is that possible? It's possible because having partners that are willing to do that, and that helps just engagement, helps more people want to come to the community, and it makes the community thrive. And that's kind of what the impetus on building the program.
Yeah.
I think it's kind of interesting too. I think Hancock Health really took a risk back in 2011. I mean, the financial incentives for this kind of care really didn't exist, and candidly, they're still pretty immature at this point. And I think that this was more rooted in a needing to meet a community health need that has evolved and put us in a position where we actually have been able to develop a product because of it. And so having this chassis and having partners, I think, are key critical pieces to starting to reduce some of this overall spend. I think if you look statewide, I think the other impetus for this really has been around we as an industry need to have a better solution rather than just a simple price increase every year to employers that incur more cost. We ourselves, when we were a self-funded plan, saw it too. So we managed it and saw it at the same time. And so I think you'll hear us talk a little bit later in this conversation about what are some of the intentional things that we have tried to put together to make this program very sticky in terms of providing data and insights to employers as well. So I think it's a part of trying to an ever-evolving solution at this time.
Yeah, and then Matt or Joel, to either one of you, a lot of this, a lot of people have concepts and they have ideas without implementation. What kind of took this from a concept to then the commitment of, okay, we're going to dive in and we're going to do this?
One of the beautiful things about independent healthcare is that we're big enough to be really interesting, but we're small enough to move really fast and agilely towards innovative ideas. Because we don't have to deal with solving a problem that requires a grinding bureaucracy to do healthcare border to border in Indiana. I get to solve a problem for the people of Hancock County and the areas that we serve around that. And that impetus, to your point, the ability to move fast, and my background as an engineer, and then I spent a lot of time in startups and venture capital before coming back to Indiana. The one thing that drew me to Hancock Health was the idea that we could move fast and we can solve these problems. We had leadership that was willing to invest in doing it differently because we knew the puck where it's going. We have to skate there, that we can't be paid to put people back together forever. We have to be moving towards how can we incentivize folks to make the decisions that reduce that total cost of care to drive engagement, because the real currency of healthcare is engagement. The floor is access, the ceiling's engagement. Everything in between is what you can accomplish for your organization. And I think to the point of the conversations earlier, that engagement and our ability to create something that help people say yes and stay yes to those healthy behaviors and sustain that change started to bear out. And when we saw, to Matt's point, that, wow, we as a vertically integrated system with all the infrastructure to do lifestyle medicine, physical activity, access to care, managing the pharmacy component, finding the partners. When you put it on the chassis of delivering that in a health plan to individuals, I've vertically integrated all the levers that pull on risk that other systems don't have. They'd have to go grab a bunch of point solutions and try to stack them up or find a bunch of partners. We had it all in-house. And we thought, wow, gosh, we'd be crazy not to help our employer partners and help our community pull on these levers of risk in a way that really only we can. And to put an asterisk on that, this idea of the infrastructure of well-being or integrated well-being campuses, we are international thought leaders on that. And I'm not kidding when I say people come from all over the world to see that ecosystem that we're describing, most recently, the United Kingdom, Newfield Health. But this concept of health systems vertically integrating courageously on something that is only going to reduce the demand for the things we actually get paid for at the main campus, that took some incredible foresight and courage by our board of trustees. Yeah, that is directly antagonistic to how we make money and how healthcare makes money. But we know we can't live in that world forever. It's not tenable, to Matt's point, for our own people. And as a large self-funded employer that we've had to navigate those waters as well. So you got to drink your own Kool-Aid. We had the ability to move quickly, to innovate, to pilot things quickly, pivot or persevere, and treat this like a startup would. And now we were able to land and then expand that impact in a way that started to now bear out, not only in cost avoidance and these capitated structures, it allows us to participate in two-sided risk in a way that no other system can, because I can pull levers no other system can, because they don't have the infrastructure. And you're going to see with some of the initiatives that are coming down from the federal government, whether that's provider level quality incentives, shared patient savings, CMS is talking about it, and it's going to happen at the Medicare, Medicaid level, all the way to Make America Healthy Again, Elevate programs. They're finding ways to start to incentivize health systems to do what we've been doing since 2011. And there's going to be a massive, oh gosh, trying to pull a bunch of point solutions together. What's interesting is programmatically, this idea of the infrastructure of well-being, you can build it wherever you are with a health partner that's willing to lean in by bringing these together. And again, if you have a partner that can also get this embedded into your health plan or your approach to benefits, you're cooking with gas.
And if I can give you maybe a practical consideration as you leave today, and maybe you're thinking about trying to find a health system in your locale that might be doing this or thinking about this. I think one of the things that Hancock brought to the table that was unique was we're on a single source EMR and ERP system, meaning all of our sites of service, including all of our physician practices, our immediate cares, our wellness centers, our hospital, are all on the same system. While that may seem straightforward to all of you, what that means is that we have the data capability to really data mine and understand the patients that are a part of these programs. We talked about a lot of the programmatic, the A1C program just a minute ago. Being able to flesh out some of those insights is absolutely critical. Joel's absolutely right. A lot of other health systems right now have to go out and source multiple point of source programs to do that. And so that might be a question that you would consider asking your local healthcare provider is, what is your IT and data infrastructure? And are you actually prepared to give us the insights we need to control these populations?
Yeah, and then Guy, from your side too, on the group side, what kind of took for the commitment for the groups to be like, okay, this is something new. Obviously, we talked about not a lot of people like change. So what was the buy-in, or what was the thing that really made these groups think, yeah, this is something that we think would be a good solution for us?
Well, they didn't at first, just because the response was there's got to be a catch. That just sounds too good to be true. Why would you put a $0 deductible plan, give it to a small employer like myself, and or we're buying into a large group that's going to just, kind of flush us out, or and we're not going to have control. And because we're able to do it on the group level, underwriting individually, and letting them know that they have a direct contract with the hospital, just the light bulb just went off, and they said, wow, if I can control my cost by going directly to the hospital, I'm going to reduce the cost for the employee, which gives them better care. They get full access to the direct primary care and all of the DPC benefits, and they're increase their benefits tenfold. And then they're either cost stage neutral or it comes down just because the cost of care came down. So that's where the engagement came in, and it's just, there's interest that keeps on growing. Every time I go out and I talk with people about how the program is and how it's going to impact the community, and we're keeping the money local. So the money stays local. I mean, I'm going to see these people at Meijer. I'm going to see them at Walmart. I'm not going to just put a program out there that I'm going to be regretting, while I see these people. So this is my community. I want to make sure that it flourishes and it gets healthy and it becomes number one or number two, in our state.
And to the price point, I think if anybody's experienced, and let's pick on, you wander in to see a doctor and you're establishing care for the first time and they spend 45 minutes with you. In our world, that's an evaluation management code. Many of you know this. Let's call it a 99204. You would probably have plan spend hit of about $250-ish, $225, somewhere in that ballpark, right? Now think about the incentive structures that we typically have. Post-pandemic, most patients forewent a lot of care they should have gotten. They're showing up with higher acuity, sicker patients. They've also transitioned to high deductible or ultra high deductible plans by way of just what's hitting the pocketbook. So now they're incentivized to not spend on healthcare until it's a really big problem you can't avoid. And then they show up, they receive a service with us, and on our side of things, we have to play the game with typically a commercial insurance company where you have to factor in the idea that you won't be paid for 90 to 180 days, that they're going to hold on to it, that you can win an appeal. My greatest example is if anybody's been to Chick-fil-A, imagine your experience at Chick-fil-A was like this. You go up to the counter, you order a number one, you get a Coke Zero and some waffle fries, and you go back to your seat and you eat it, and it's fantastic, right? The chicken sandwich is heavenly. It's the Lord's chicken. There's the waffle fries. You drink your Coke Zero, but then my buddy Matt goes up to the counter for me. He says, hey, Joel really loved his meal. It was awesome. He's done with it. Here's the $1.20 for the Coke Zero. You can appeal for the rest. That's insurance every day. And a lot of people don't know that it's often after we render the service that then we have to go fight it or don't get paid for the services at the contracted rates, et cetera, et cetera. Do you know what gets priced into that entire $250 we talked about? Playing that game for 90 days to 180 days. Guess what happens if we don't have to play that game? The cost is incomparably lower. If people can't believe it, like our direct primary care clinics, a great example. Unlimited primary care, unlimited generic medications as medically necessary, unlimited labs as medically necessary, unlimited health coaching, free clinical exercise referrals and wellness center participation. All of that for somewhere between $55 to $65 a month per employee, not per member, per employee, to cover that employee and their whole family in a capitated way. And it's better for us from a margin standpoint than playing the game with insurance companies. So that gives you an idea on when you talk about the cost of healthcare, and this is why I go back to the total cost of care, to Guy's point. The reason something like this, when innovative things can happen, is when you get everybody aligned on that bouncing dollar landing on you, your people, a provider, or the community, and not Wall Street. There are incredible savings to be had for everybody involved, and everybody can win. And we're now starting to lean into that big black box that was the arbitrage for how healthcare costs has just gone up and up and up, and say, well, what if it didn't? And what if all of us working together could repatriate those dollars for the health and well-being of your people? And that's how this is working now. And that's why we're able to work with Guy and Connor and folks to bring something that was otherwise you wouldn't even think possible at a price point that is accessible with all of these baked in advantages where access to Hancock Health is the tier 1 provider in our plan means that experience, the copay, the co-insurance, the deductible that you typically hit you, gone, it's in the premium because of the pricing we can agree to when you go directly with us. Other health systems are interested in this too. If they're not, find one that is. because we don't need to be that fee-for-service black box.
And that was gonna be my next question for other communities that are looking to implement this, specifically on the structure side. Matt, I know you've worked with over 170 hospitals statewide. What foundational elements really need to be in place for something like this to work?
Yeah, I think there's a couple different things that need to be looked at. I think number one, don't discount the importance of a community health needs assessment. It is a great way to understand a community. And more importantly, the gaps in care that it itself perceives as a problem. Because I guarantee you, part of that feedback in that report is a great way to go to those local providers and saying, how are you addressing this? And bring employers to the table at the same time as well. On the provider side, I think it is finding entities that are opening their eyes to taking on more risk on this side. Joel just illustrated kind of the price arbitrage that's out there. Why hospitals candidly love programs like this is because it's reliable, sustainable revenue rather than what has to be adjudicated through a claims approval process with our payers. And so I believe there are more conversations that can be had because of that. I want to double down on the data and the IT side again. I think that this is a critical component that early on, when we all started doing wellness in the hospital space, we probably didn't have the best understanding on how to pull this information forward. Payers were short in providing information. Our wonderful TPA partners were pulling their hair out trying to get it for us. Find a provider that actually can house and pull that information from their own data systems. That's a way to kind of circumvent those issues in general. So I think those are kind of three foundational areas that I would look.
And then Joel, I know we just talked about with ASC, they have all that engagement, and a product can be fantastic, but if you don't have people engaging, then it's not really doing much for your plan or for your people. What is Hancock Health doing out in the community, really focusing on the engagement and trying to push people inside those local care deliveries?
Going back to it, that's the only metric that matters, right? So our direct primary care clinics, we're capitating unlimited access to direct primary care, right? So we get paid whether you use it or not. But guess what? If you're not using it or they're still running it through the plan, you're double dipping, and I'm going to advise you do not engage with us because you are wasting money, right? It's our job to drive engagement. It's the healthcare system's job. We work with our employer partners on that front. But engagement in the right front door of healthcare, which is the problem typically. It's the site of service problems. It's getting there early and often when the cost is low or capitated. That's the only way that you reduce the burden of risk over time. So for us, when we think about engagement, we've been doing it in a retail capacity since 2011. So we've had a major head start where we don't treat people like patients, they're treated like consumers. And healthcare is moving towards a consumer expectation. And you're seeing that left, right, and center. And the idea that we can meet them where they are, we're wrapping them and we're being first because of our ability to be innovative, first across the line with some things that other health systems are toying with, like AI, medical companions, the idea of a loyalty program for a health system. We actually have one. And it rewards people for the safe harbor, well-being incentivized behaviors like getting all your preventative screens, connecting with a primary care physician. And this is what's crazy. Probably upwards, I'd say about the average, if you look at some of the data, is about 41% of any self-funded population employees with insurance don't have a primary care physician relationship. We've seen up to 60% in some of the employers that we work with. So the front door for healthcare is now becoming TikTok and Instagram, YouTube. They're getting all kinds of information, but not connecting with a healthcare provider that can help orchestrate and utilize that information. So for us, we want to be the orchestrator, a source of truth for that. We want to create access where we meet people where they are and we don't leave them there. We come alongside them and we elevate them along with our community. And all of that goes back to how do you get more people in an arrangement that removes the financial and the logistical barriers to accessing care early and often? And how do you create structures, whether it's benefit, wellness programming, actual cost, the incentives in the community for them to do that? And I'll give you guys a great example. Also as a plug for the wonderful panel that you just listened to about GLP-1s for diabetes. As a self-funded employer, we had a problem very similar, which is, yes, we'll cover it for diabetes. What were we going to do about the weight management indications? And to echo Ben, you can't afford it. The indications are almost everybody. For us, it would have been an extra $5 million to make the GLP-1s available to our population we knew were indicated for it for obesity. alone, let alone all of the other indications that are coming out. So one of the access points that we drank our own Kool-Aid for our own people was, what if we created a weight management program that wasn't a benefit, it was a wellness program with an application process, very much like they just described. You have to apply to get in, you have to meet the indications for needing the medication. We will pay for the med, full freight for X number of people that we can afford. You're committing to a year, you're meeting with my health coaches, you're going to meet with our lifestyle medicine physician. You will have to go to the wellness centers 8 times a month. You will meet with the dietitian. And if you hold up your end of the bargain, we'll pay for it, full freight. And at 8 months, we're talking about the exit ramp. And when we got this kind of engagement, very similar results. 90+% of people finished the program. 60% of them transitioned off of anti-obesity meds. We achieved benchmark clinical outcomes, but not everybody started on the medications in the first place. We weren't even using GLP-1s for this entire population because we have a clinical exercise program that if it were an FDA cleared pharmaceutical product, my clinical exercise program, it would be an FDA cleared anti-diabetes medication. In 8 weeks in this program, we moved the needle enough on A1C with physical activity and nutrition to be cleared by the FDA as an anti-diabetes med. So think about that. There's power when, to the point of the panel earlier, you don't think about just access as the goal. It's not just getting the drug. It's not getting the people to do X, Y, Z. It's sustaining towards an outcome and making sustainable lifestyle change the goal that you can afford. And if you can answer that question, you're now optimizing for what's going to move the needle on your total cost of care.
Well, on the access side too, not only is Hancock County becoming one of the healthiest counties, they're also one of the fastest growing counties. So I'm guessing with implementing this for as far as the hospital infrastructure, Matt, how have you guys been able to, with, I'm assuming, a lot more intake and a lot more people, what does that look like on the hospital side?
Well, it's kind of funny. If you, not to pull the curtain back too much, but candidly, strategies like what Joel's talking about in the infrastructure of well-being, it runs in conflict with traditional hospital operations. Traditional hospital operations are focused on volume, because in a fee for payment mechanism, that's how hospitals are successful. I think what we have had to do is have some very intentional conversations at Hancock in that we actually treat our well-being as a service line. And let me explain what that means. Most hospitals, I'm sure if you just see local advertising around, are talking about their cardiology programs, orthopedics, cancer care, other things like that. We consider our wellness program akin to that level of service line, which means we staff for it, we resource it, we give it the infrastructure it needs to be successful. I think where a lot of providers have gotten into, and maybe not trouble is the wrong word, but at least haven't been able to realize their full potential here, was that it wasn't treated like a service line. It was treated more as a check the box. We're going to comply with a state regulation around making sure we have a direct to employer plan and whatnot. You're right. Hancock County, depending on what poll you're looking at, it's either the second or third fastest growing county in the state. There are, we're blessed to be able to look at models or counties that have gone before us and to see how, they've gone down this road. So we're learning from them as well. Strategically, the wellness centers where we locate them are in high growth areas in terms of the county, McCourtsville and New Powell and in Greenfield as well. So downstream, we expect to see this as a mechanism that continues to keep Hancock Health a local provider.
Great. And wrapping up, because we're coming up on time, and I want to hear each of your guys' opinions or thoughts on this. From an employer or community leader that's maybe sitting in the room today, what's one question they should go back and ask their team, ask their community? So, Guy, for you, for employers, what should they be asking right now?
Are we willing to step out and just look, or I don't want to say take a risk, but just look at different ways of managing your health plan? It's not, there's many ways of putting a program together that have a lot of different levers that you're probably not pulling. Start looking at direct to hospital, direct primary care. Look at different wellness programs that you have. Just look at the whole program and then get creative. Get creative with your advisor. Get creative with the firm that you're working with. Get creative with us. Just get creative when you're talking about your health plan, just because you have to figure out, how do we get the employees engaged? How do we get the cost of care down? And I think that's probably a question I think you should ask, when you're in your overall committee meetings, just to find out, are we doing everything we can possible to help drive down our costs in the healthcare?
And then Matt, for you, what should communities be thinking about right now, and what should they be evaluating about their current approach?
I'll go back to truly understanding what are the community health needs of the area that you're serving. I mean, at the end of the day, they're probably common among most of us. It's access to care, it's access to mental health resources, it's trying to find ways to deal with the obesity epidemic in our areas. But using that as the opportunity to convene the necessary parties, the providers, the employers, the brokers, and candidly kind of letting our walls down a little bit and saying, we are all trying to attack this problem the same way, or in different ways. How can we find some commonality, use programs like this, and what resources do we have internally right now that could be held in a unique fashion to drive proven results?
And Joel, what's one action step someone could take in the next 30 days, could do it as soon as they leave here, that you would recommend?
I'm going to give you two things. One is very practical, which is take an approach of land and then expand. So pick one thing, one condition, one cost driver, and find the right provider in your community that's willing to have a conversation like what we've been describing today. And you may be blessed with one, you may not, right? But you need to, I would ask, and you'll be surprised what you can do with a hospital system that wants to lean in, and again, not be that black box where your spend goes to die. So don't be afraid to ask, to Matt's point. The ability to convene, the employer has that power, much more so than you think you do. And you are the stakeholder where if you win and everybody else can win, and all the boats rise with that. And that's, again, back to my first point. It's not just a health at an individual or family or even your employee population issue. It's an economic development issue for entire communities. So that's number one. Number two is take whatever opportunity you can to learn more about how these systems work, because we're in a time now with some very interesting and trying legislative approaches to this. And the idea that you'll hear it left, right, and center, that hospitals are flush with cash and they're making all this margin and they're doing so great. And look at the Medicare cost reports. Those are the wrong data sources to make those kind of determinations. And I would argue, why are systems shutting down and why are they consolidating and why are they dropping their labor and delivery and obstetrical care if things are so good, right? Price controls and price as the only lever that you pull will leave you with only a few options in healthcare statewide, because the only way that road ends is consolidation. And consolidation, last I checked with my economics classes I've been able to take, that doesn't work out so well for the consumer, right? So one of the things I would caution you, when you think about, again, macroeconomically, healthcare is a total cost of care problem. You need to have the data that looks at what is your total cost of care, and you have partners, to Matt's point, that are willing to lean into that data and help you diagnose what are the root causes and what levers can we pull to reduce that. And the more that you work innovatively with health systems, the better the solution becomes for everybody, but also the better the access and the more proximate to the needs of the community. You can be a driver for that, because the future of healthcare sitting in this room is you're going to have control over, at the very least, your own. But in often, many cases, you'll have control over that destiny for hundreds, if not thousands of people. So take all of that with the level of responsibility, I think, to educate yourself as to how it actually works, who are the stakeholders, how are they incentivized, who gets paid when, where, and why. And that bouncing dollar will tell you a lot about whether or not everybody can win.
Yeah, it sounds like being ahead of the curve isn't just about location. It's just being willing to align, incentives differently and ask better questions. And Hancock County chose to kind of take the torch and do that. And especially in 2011, well before that was probably thought of, where wellness was the question that we were hearing all the time. I think the real question is just, could your community do this as an employer? Are you asking the questions to your broker, to your providers, and seeing how this can implement where you are based off of? I just want to say thank you to our panelists. They'll be here afterwards, so feel free to connect with them and continue that conversation. But if we could give them a round of applause.
Thanks for tuning in to Risk and Resolve. See you next time.